Can everyone see my screen?
Yes.
Okay, perfect. Let me hide this. Great. Thank you all for being here. I know that we are all working really hard and it's a really weird time. So I hope this is maybe just a quick relief of thinking about COVID-19 and all of us working to support our patients. I'm really happy to be here. The only caveat I would like to kind of say is that I have been known to talk really fast. So I am going to put myself in slow-mo today, which is going to sound really weird for me, but hopefully it'll make this presentation and the contents of it be more palatable. So thank you all for, again, being here, and I'm really excited to talk about quality improvement. It's something I'm really passionate about, and I think it has a really important place within the healthcare system and supporting patients. I do have a few quick videos tagged within my PowerPoint, so fingers crossed that those work, but please bear with me if I'm having any technical difficulties. I will muster through them. So today we're really going to be just talking about what the basis of quality improvement is and why people should be interested and care about the quality improvement initiatives. Like I said before, I think that there's a really important role of quality improvement within any healthcare setting. And today my job is to help convince you of that, basically, and provide you with some tools that if you're interested in learning more and thinking about how this fits within the clinics or the patients you support, that I do that. So just a quick little bit of information about me. I do work at the Colorado Department of Public Health and Environment, and I'm the Cancer Health System Specialist there, which that title doesn't mean very much by reading into it. Essentially, I do clinic quality improvement, and I lead the cancer prevention and early detection program for the quality improvement strategy. So this is a grant program that a lot of FQHCs and a lot of different like safety net clinics apply to participate in. We do a lot of breast cancer, cervical cancer, and colorectal cancer work. I also co-chair the Colorectal Cancer Task Force, which is a part of the State Cancer Coalition. And this is just really a coalition that helps bring a lot of stakeholders that are interested in and vested in supporting and improving the work of colorectal cancer within the state. And then I also am the Colorectal Cancer Control Program Manager within CDPHE, which is a CDC-funded grant that we received to help support colorectal cancer control within the state. So obviously I am really interested in colorectal cancer, but clinic quality improvement as a whole can really be in any stage of, or any disease, or in any kind of amphitheater of a health system. There's a lot of work regarding patient safety and improved patient outcomes. In my previous career, I did a lot of quality improvement with patients that had chronic disease. And I worked in family medicine and I worked in specialty clinics. So CQI has a role really in any aspect of healthcare and taking care of patients. So just a quick overview. We are going to be talking about quality improvement. So we'll start with an introduction to quality improvement. We will talk about forming the team, which is really thinking about quality improvement and how we can get the right people in the room to be thinking about quality improvement within everything we do every day. And then setting the aim, establishing measures to determine if an improvement has been made, selecting the change or intervention, testing the change, implementing the change and spread, and then resources. So I just also thought I was being really creative, because this is also really the steps that are kind of numerical order of how you start a quality improvement project. So I not only wanted to set this up in a good, logical manner, but I also want this to be a resource for all of you as you think about quality improvement within your clinic, or you're interested in getting involved. This is kind of the core framework and the order in which you do things. So I hope that these slides can be useful just outside of the presentation when you go back to your clinics and support your patients. Okay, first technical challenge here. Let me see if I can't get this video to play. And it's just gonna be the first 2 minutes. So fingers crossed. Okay, can everyone hear that? It just said, I'm Dr. Mike Evans.
I can't at this point, Meg. I'm wondering if you stop sharing and then share on the screen of the video, if that might work.
Okay. Let me see how I do that. Stop share. Okay.
Quickly, Connie Fisher, I did see something early, and I think it's earlier in the chat that you were having a tough time. Are you hearing okay now? You guys can write it. Everybody hearing okay? There is a little bit of a background noise. Elsa, are you able to mute everyone else?
Yes.
Okay.
Okay, Elsa, I'm gonna try this now. Will you let me know if you can hear it? Could you hear that?
I can't hear it.
Okay, let me.
Meg, there's like a little bit of background. I can hear a tiny bit where it sounds like other people are having a conversation, but also we have everyone else muted. Is that correct?
Yes, and I will double check.
Okay. I know that everybody on the planet is using Zoom, so I think there's a small chance that we can probably just anticipate a little bit of IT craziness. Meg, is it good enough that I think it's good enough for us that we can hear you if you keep presenting? Is it super distracting to you?
No, it's not distracting to me. I actually don't hear it, so.
Okay, all right. I think we're good to go. Let's see what everybody's saying in the chat. What do we have here? Try hitting share. I think you have to change the audio source from you to your computer. And I think, Elsa, you can only mute people who are on the Zoom connection, but not on the phone. Is that right? Or can you mute everyone?
I can, but I'm not hearing any feedback.
Okay.
And it looks like everyone's muted.
Okay, that sounds good. I think, Meg, we're probably good enough to keep moving. I know there's a little bit of weird sort of background, but I think you can override that if you keep going. And it doesn't seem like anyone else is hearing that much either, so, okay.
I'm gonna try to change this one more time. Speakers, same as system, huh? That's right, audio settings.
And if not, we can definitely share the video link with everyone and recommend they come back and watch it afterward.
Okay, let me try this one more time. I'm gonna try turning this up. And if not, then we can just move on. Let's see here. Can anyone hear that?
I don't hear it still.
No? Dang it. Okay. I am probably going to, let's see, there was someone, I had something in the chat. Oh, someone said yes, that they could hear it. Okay, I'm gonna just let this play for just 2 seconds and then I'll give like a quick, I'm gonna let it play the 2 minutes. And then I'll give just a quick overview of like really what the gist of it is. I think the important things are just kind of what he's drawing and what this could potentially look like. So I'm gonna give this a try. I'm gonna turn up my speaker too. Okay.
Truly curious person who never thinks they have a whole.
Okay. So that was just the 2 minutes I wanted to share. Thank you all for being so patient during this technical time. If you could everyone hear that? If not, I can give just a quick overview.
I think a quick overview would be helpful.
Okay, perfect. So really what that was just a quick, it was a quick video that's talking about like what quality improvement is. And it's really essentially this idea that we don't necessarily have to solve all of the problems, but as long as we're working to improve, that's where we can use methodology, we can be curious to help support our patients. And this model for improvement has been around for quite a long time. Toyota does this in terms of manufacturing. What's the most efficient way that they could build a car or get parts out the door? Bell Labs has also done this, and it's basically systems thinking. So how can we improve a system through organized scientific model, but we can think of this more in terms of healthcare. And we don't have to know all of the answers, but I think we have to be curious and open to change, which is essentially also what we want within our patients. We want our patients to be open in thinking about change and improving things, right? How are they going to address their high blood pressure if they are not willing to improve? How are they going to be able to think about cancer screening if they're not willing to improve? And so it's really this idea and this curiosity of how can we make things better. Okay, so I'm going to move on to what the model for quality improvement is. And it's essentially...
And Meg, real quick, we're seeing your calendar now, so if you wouldn't mind switching back to your slides.
Well, that is probably the most boring thing to look at. Okay. Can you guys see this now?
Yes.
Okay. At 4 o'clock, I have to go get my dog's medications. Okay, so this is the model for improvement, and it can be breaking down into a few different kind of checkpoints. There's these 3 questions that we would like to address before we kind of go into testing changes. So the first one is really relates to setting aims, and the aim should be really what you're trying to accomplish. So it should be obviously timed out, measurable. It's a way to define a specific population or patients or of a system that you would like to improve. The second is about, so how will we know this improvement is going to result, or how this change is going to result in an improvement? And that is essentially establishing measures. So teams can use different measures to determine if a specific change actually led to an improvement. And this is where data can come in and play a really big part within quality improvement. The final question before you would actually start to test a change is ideas that may come from those who work in a system or experience of others who have successfully improved. So it's essentially, what can we do that will result in an improvement? It's almost like the intervention. And then the last little plan, do, study, act box is really actually testing the change. So if we think about this and give an example, say you are looking to improve your commute into work. Okay, you collected some baseline data and it took you 35 minutes and you always got stuck in traffic and it was a really tough start to your morning, and you want to find if there's a better way that you can improve this whole process for you. So that's the answer to the first question. What are you trying to accomplish? You're trying to improve your commute. The next one is, how will we know that a change is an improvement? So that's the data. How are you going to know whether your commute was improved? Are you going to measure the time it takes for you to get there, your overall satisfaction, whether the route was pretty? Those are all things that could lead to help you make a decision about whether an improvement in terms of your commute has been improved. And then what change can we make that will result in improvement? Maybe you leave earlier, maybe you take a different route, maybe you carpool. All of these things are things that you could essentially test to see if an improvement can be made. And the testing part is where the plan, do, study, act comes in. And this is meant to help you organize how you're going to test something. So you'll plan it out, you'll do it, you'll collect some information, then you'll decide and make an act on whether you should modify this, adopt this, or just abandon the whole test altogether. So this is really the organized kind of fashion and how you determine which route you want to take to work. Okay, let's see here. I can't change my slides. Okay, there we go. So again, this is, I think, just a good snapshot of what the quality improvement should look like within a health system. So say you identify a problem or an opportunity to improve, you assemble a team to determine what you want to do, how you want to make an improvement, how you're going to know an improvement was made. Really, the model for improvement that we just talked about is really what happens in step 2. Once you assemble that team, that's where you go back to the model and can kind of start there in terms of identifying what you want to change and then tracking that. So a multidisciplinary team is critical. And the nice thing about quality improvement, it's very inclusive. There are no bad ideas, and there is not anyone that isn't welcome within the whole process. And I think leadership and anyone that's going to be involved has a place at the table for quality improvement and being involved within the quality improvement team. The next step would be to collect some baseline data to better understand where an improvement could be made. So if you think back to your commute, maybe the first couple of days before you take a different route, you want to just see actually how long it takes you. What does it look like? Your normal route, 35 minutes, 38 minutes, 40 minutes, what's the average? And where are the hiccups in terms of your commute? Step 4 is to finalize the measurement and the plan to tackle the QI tool. So this is really the test. You've answered those 3 questions, you've made a plan for testing it, you have some baseline data. Step 4 is to kind of start doing it. Step 5 is to continue to evaluate whether you're making an improvement, check in with your QI team, provide updates on progress and support. So really, how is this going? Talking with other people, maybe thinking about what routes they take to work. And then step 6 is to study, track, and evaluate whether your project is going as well as it should be. And then this is almost a decision point. So oftentimes with quality improvement, you don't just kind of do one test and it works magically. Usually there's a few different tests. So thinking about your commute, you test just street distance. What is the miles, right? So maybe you found a route that is 2 miles less than what your normal route is. And then maybe your next test is time. So thinking about the least amount of traffic, maybe you avoid the highways. And then next one is just your overall satisfaction. Maybe you try carpooling. And so it's those small little tests that should help support and lead you to a decision, which then you can make your best kind of guess on how you can improve your overall commute. Okay, before I move on to the next one, the next is really going to be going into the steps of quality improvement and the steps that we just discussed. Does anyone have any questions at this point in terms of what the purpose of quality improvement is? And next, we're going to talk about how you do it. Okay, if you do, just go ahead and put them in the chat box. And we can, oh, there was a few. Elsa, would you mind just reading those to me?
I'm not seeing any questions yet. There was just a couple of things when we were working out the technical things, so I'm not seeing any questions quite yet.
Okay, perfect. I'm going to keep cruising then. So next is really that first step that I kind of talked about. It's forming the team. The who and the why is really what we're going to be talking about. And so who should be on a team? So say we could talk about the commute again. Who would you want on your improvement team? So say you already carpool, or say you're trying to improve a process within your clinic to decrease wait times. Let's use that one. So you are part of a busy clinic. Who should be a part of your team? And effective teams should include members representing 3 different kinds of expertise within the organization. So leadership is usually really important, technical expertise, day-to-day leadership, and there could be other individuals that have expertise or individuals that have experience in an area. But regardless, multiple different people should be represented, and there should be multiple different viewpoints. So thinking about this process, who should be involved? I think probably if we want to improve the overall clinic flow, really anyone that touches kind of the process. So I would say your front desk, maybe your nurse or MA, the provider, practice manager, maybe you have a designated quality improvement manager, someone who discharges the patient from being seen, patient navigator, and who else? Who else would kind of have a stake in this process? I think a patient would. Oftentimes, patients can be a part of quality improvement processes. You don't necessarily have to, we don't necessarily have to have share kind of PHI or anything like that, but we can gather information from patients about their experience and kind of allow them to be a part of the QI process. Okay. Next is
Meg, this is Andy. A quick question for you. So, like patients, would that be satisfaction surveys? I mean, I guess if we include patients to really think about that, I know that you're talking about not making sure to include protected health information, but what would that look like in terms of adding them into the QI process?
Yeah, that's a great question. And that's really up for you to kind of decide. If they are, if you have a QI committee, they could be a part of the committee where you're just talking about the overall process. You could have, you could survey the few patients that come in and you can collect some satisfaction information from them about the new change. But not forgetting about that patient voice is pretty critical, just especially if you're going to make an improvement that's going to affect them. And that is really up for kind of you and your clinic to decide. If you have a great working relationship or a great relationship with a few patients that could come in and be a part of your quality improvement committee, that has been very successful with some instances, or you could do some interviewing. There's really kind of no best practice, but the best practice is including them. So if you have a monthly QI committee, sometimes they might come and be and just talk about their experience, talk about what was hard for them when they were being seen, or potential areas for improvement, because I think as healthcare professionals, we see kind of one side of the coin and patients represent kind of that other side. And so making sure that we're viewing kind of their experience is really important.
Good suggestions. Thanks for sharing that.
Yeah. And that's, I think the patient experience and kind of their voice is important. I think making sure you have the right people represented in the clinic is probably the most important thing. But I think being very clear with expectations and what you need from the patient is also very important. So sometimes patients are really involved in a patient advisory group, or they are just consulting on a project if they are interested in making an improvement within their clinic. So it's not like once you engage a patient, you have to work with them forever. You can engage different patients. So maybe you want to engage a mother because you're trying to improve like well-child checks, or you want to improve patients that maybe you'd be at a fall risk because you're trying to beef up your fall protocol in terms of decreasing like hip fractures. Those are all things where you're going to want to engage different populations. Okay. Can everyone still hear me okay?
Yes.
Okay, Great, thank you. Sorry, I'm having such technical difficulties, and working from home, my partner is also on a conference call right now, so I'm trying to find a quiet place. So my apologies. The next thing that we should be talking about is setting the aim. So you have your team, you know what you want to do, or you have an idea of where you'd like to make an improvement. The next is just setting that aim. So thinking back to making sure this is smart, measurable, achievable, it's related to the work that you're doing, it's time bound. And I think what can happen, or the biggest hiccup in setting the aim, is really setting it too broad or too big. So your aim should be, again, thinking back to being specific. You can have multiple aims. You can have an overarching project. So say you want to improve the overall clinic flow. Maybe your aim is just to address like the front desk issues, or address the rooming process. So there's going to be multiple smaller projects kind of within this big overarching kind of idea. But your aims should be very specific to the test you want to do. So they should be very small, very targeted, very specific. And it should be very focused. So you want to solve world hunger, you want to start small and very specific and be very focused, because you can't do that all in one kind of go. Okay. And next is establishing the measures. So this is really where you know if an improvement's going to be made. This is where data can come in. It can be baseline data. It can be data that you have gathered about where you could potentially make an improvement. And there's really 3 types of measures. There's process measures, there's outcome measures, and then there's balancing measures. So the 2 that I think are really critical, especially in new, smaller projects for quality improvement, are process measures and outcome measures. So this is where my second video comes in. And I don't think sound is important, so I am just gonna play it. Let me see here, so sorry. This video is going to show, I think, a good relation on how the process measures and the program measure, or process measures and outcome measures really relate to each other. So, okay, let's just watch the graphics for this. I'm not going to worry about sound. Okay, so you're golfing and they keep hitting the ball off into the ditch and it's not going straight. So you have your coach and your team that's standing behind you, and they're like, you need to fix your grip if you want that ball to go straight. Okay, so they fix their grip and she swings. I'm gonna speed this up a little bit. Okay, this is what I want. So your process, right, is how you grip your golf club to make it go straight. So if you grip it one way and you keep slicing it off into left field, you have your team that is there to kind of help correct you. And then you self-correct, your process changes, therefore it results in a better outcome. So that ball then goes into the hole. It's right down the middle, perfect form, you had the help of your team, So the process directly relates to the outcome. So by improving a process, you should be able to improve your outcome. Sorry, that video was probably not needed, especially if you couldn't hear it. Okay. Can you all see my slides now?
Not yet.
Okay, there we go.
Yes, now we can.
Okay, perfect. Oh, shoot. Okay, so the process is how things are moving. The outcome is what is because of the process changes. So we think back to that busy clinic. The process was you changed the patient workflow, you made the check-in process really easy, you didn't have them sit in a waiting room, they went right into the room with their MA. So say you made this change that's process, so that's any data that has to do with that process. The outcome would be improved patient satisfaction, or improved or decreased wait times, or improved how late a provider was with seeing a patient. So the outcome usually has to do with patient outcomes. Sometimes they can be clinical outcomes. So say you want to focus on how you prescribed your diabetes medications to your patients. Maybe the outcome is better managed care. So there's a few different ways you can think about process and outcomes, but they usually relate to each other. So how do you do this, right? It's how you track the data. Maybe you're tracking weekly data, maybe you're tracking daily data. It all has to do with kind of the project that you're thinking about. But really what is important to know is the difference in how it is being displayed over time and kind of what that changes looks like. And there's a few different data tools that you can use to kind of display data that can help inform decision making. So there's run charts, there's control charts. I know that this graph is kind of hard to see, and I don't think the details of it are important, but I think the important thing is that this data is kind of displayed over time, which will help you then kind of see what is happening within your clinic to decrease like wait times, I guess, or increase patient satisfaction. And you can also track the changes that are being made in your decision points. So where a change was made, maybe it was made on the second week, and then you see a decrease in wait times, and so you know that that change that you made actually resulted in an improvement. So data is really important. Okay, the next is selecting the change or the intervention. And sometimes these are referred to as change package, change concepts. They can come to you kind of already pre-developed, or you can make a change package or change concept based off of your clinic. And it's meant to be just a general notion or approach that a change has been found and is useful in developing or addressing a specific idea that did lead to an improvement. And so we've tested it. Now we want to select which one we would like to implement. And some of the examples could include improving a workflow, eliminating the waste or that time, increased screening rates. All of those things combine the change or the concepts about the specific subjects that can generate ideas and tests for change. So after this, the next thing that we would do is actually plan the test. So this is that third kind of question in before we start the Plan, Do, Study, Act cycle. Okay, which leads me to the next, right? It's time to test this change. So how should we test it and why should we test it? So in order to increase your belief that a change can result in improvement, we need to be able to describe kind of several proposed changes that will lead to the outcome we're looking for. So say we do want to decrease wait times. These testing the different workflows, testing the check-in process, all of those things are going to help us get to that final outcome that we are trying to get to that aim. It's going to decide whether the proposed work will actually result in a change within the environment of interest, decide which combinations of changes will have the biggest effect, evaluate costs or maybe social impact or patient satisfaction. And then ultimately, it's to minimize the resistance when we do have a new workflow that we'd like to implement within the clinic. We have some substantial data to support this that will also help increase buy-in from other staff that maybe aren't on the QA team. So step one is to plan the test or observation and include a plan for collecting data. So state the objective of the test, make predictions, develop a plan to test, who, what, where, when, why, what data will be collected. So that's just really mapping out how the test is in the plan for the test. Second step is to test the test on a small scale. So maybe you just start with like 2 patients on one day and you change the workflow from them, and then you gather information about what that looks like. You document the problems, maybe unexpected observations, and then also track and look at data. Step 3 is study. That's what the S stands for. And this is really to set aside time to analyze the data, study the results, study your patient satisfaction when the workflow is changed, compare your data to your predictions. Is what happening what we thought would happen? Is this what we want to happen? And summarize and kind of reflect on the lessons learned. And then step 4 is to redefine the change, maybe adapt it, maybe make a few small modifications, and then prepare for the next test. So I think what's really critical about this process is that you don't just do one test and then you're kind of done. It usually requires multiple small tests before you can get to that final perfect workflow that you have been wanting to implement. And you have tried everything, and this is the final thing that we want to implement, okay? Next is actually implementing the change. And I think the big distinction is this is not doing the test, this is not the small scale, but you have your desired outcome. Your QI committee tested this, you did multiple plan, do, study, acts, you have data. Now it's time to actually roll this out and implement this like clinic-wide or with all of your patients. So this is why starting small is so critical, because if you implement this clinic-wide right from the get-go and then you keep changing it, it's going to be hard for staff that maybe are not involved in the quality improvement committee understand the variation in the why in terms of how changes are happening. And then really considering what the change should look like, it should be permanent. It should be sustainable. These are not tests. You have already passed that part. This is already a proven process and change, and this is the final intervention. So you're outside of the patients you tested it with, you're including it to all of your patient population. This is where everyone that maybe wasn't involved gets to know what you did, why you did it, and why it's important to implement this. And I think the lessons that I have learned, and just from my years of doing quality improvement, there's really 2 things that I think can make implementing the change really successful. And it's by having leadership buy-in. So say you have your practice manager or your executive director kind of involved with the quality improvement committee right from the get-go, because it's setting the tone for everyone else on what this should look like, and this is the new expectation. That will help make this sustainable. It will help make sure that people are interested and invested in this work, And it makes the overall kind of process much more seamless if this is supported kind of from the top. And I think regardless of whether people have years and years of experience in quality improvement, or maybe they're just there to help support the team, all of those things are really valuable, because when we come to implementing the change, you have an advocate at the front desk, you have an advocate within your medical assistant group, you have an advocate that is on the nursing team, you have an advocate that is in your provider team, you have this support staff and all of these people that are cheering this process on, which is going to make it much more seamless and be more sustainable. Okay. And I think that that's basically it. That is the overall process on how you maybe start thinking about quality improvement, how you would conduct quality improvement. There's a lot of tools and resources and a lot of people doing quality improvement. And I think that in thinking about quality improvement, the overall goal is to make things better. And in that process, you can often learn something, which is really critical in terms of making sure that we're doing the best, we are supporting our patients, and we are thinking about the outcome we want to achieve. This is just a way of laying it out so that you can make change sustainable, it can be done quickly, and it is being methodical in how you think about change. So there's a bunch of different resources out there. The Institute for Healthcare Improvement is an organization in Boston. They have a ton of resources and a ton of tools. They even have kind of data displays. They have like Plan, Do, Study, Act forms. They have a whole quality improvement essentials toolkit. And their website and their weekly emails are wonderful. It's free. You can sign up to just think about quality improvement every day, and that's linked. HRSA is also doing a lot of quality improvement work with at a system level. And then there's also quality improvement journals. So there's a lot of protocols and quality improvement initiatives that are actually published in open source or peer-reviewed journals, like the British Medical Journal, or BMJ. It's a quality journal. So this is a scientific journal, but they also have a quality journal where you can learn about different methods and how people saw an improvement. And then I think there's also a lot of resources within the state of Colorado. CCHN does quality improvement. Andy and her team knows a lot about quality improvement. And then me and CDPHE. I think the great thing that we have is that we do all get to work together, and really how we can support each other and leverage that work is, I think, really critical to making sure that we're thinking about how we can improve and support the patients and the people of Colorado that we serve, which is the whole point of quality improvement. It's making things better. Yeah, and I think that that's it. So I don't have any more slides, but the one thing I would like you to all think about is, regardless of what your position is or how you fit into your clinic, what's something that could be improved within your clinic? And what's something that you would like to see improve or support your patients kind of better? So be thinking about how you can kind of take this back and be implementing this and using this method, or maybe joining your QI committee to support your patients and think of those outcomes. I think we have a few minutes for questions. Is there anything in the chat box, Elsa?
Oh, I just realized I was on mute. I was talking and I was on mute. Sorry about that. I'm not seeing anything in the chat yet, but please feel free to type your questions in the chat, or you can come off of mute. And then I put in the evaluation of the webinar, and we will be having a follow-up session talking a little bit more about application in the safety net clinic setting on April 15th. So that information is also in the chat. I'm going to stop for a second to see if anyone wants to come off mute to ask Meg a question. All right, sounds like we've got a bit of a quiet group today. In our last few minutes, Meg, I wonder if you could just talk a little bit about timeline. So how long should people stay in the testing phase before they move on to full implementation with a clinic, and how long that overall process might take a clinic system if they're starting from the beginning to the finish?
Yeah, that's a great question. And there isn't really a perfect timeline. It kind of depends. So I would say from testing to kind of implementing or planning to testing, it's when you feel like you have enough information. There are some like rules within like collecting data that are a bit kind of arbitrary, but usually you want 10 to 12 data points kind of sustained in terms of what you want before you can really determine whether an improvement has been made. But it's really up to you and your team if you feel like you have done an extensive job of testing this. But you can also do rapid improvement where you do maybe like one PDSA a week to kind of get to your desired outcome and see what the data says. It kind of depends, but it's really meant to be determined within your kind of QI team. But I would say usually testing things for multiple weeks is the best kind of way to go, knowing that you've started really small. But if you're need more time, that's okay. It's really kind of up to you and your team. That's a great question.
Great, thank you. All right. Well, it looks like we didn't have any additional questions come through. We will send a follow-up with the link to the recording and Meg's slides and the evaluation link again. And I will also send Meg's contact information if you're okay with that, Meg. So if anyone has a follow-up question, you can reach out to her directly.
Yes, thank you so much for having me, and thank you so much for your patience during the technical time. Man, those I encourage you to the videos are linked and embedded within the presentation. I encourage you to take a look at them. I got them actually off of the IHI website. There's a lot of great videos and kind of introduction to quality improvement on there. Thank you so much for your patience. Working from home is not easy. So thank you for not yelling at me.
Thank you, everyone. Have a great rest of your day.